All right, welcome everybody. I'm Tom Ryan with Provider Outreach and Education, and I'll be your presenter today. I'm also joined by Karen from my team. She is going to be your chat host today. Her job is to go through and monitor that chat, make sure you're getting the information that you need. She's going to put some additional resources and other things down there for you. Today, we are here to cover Medicare Secondary Payer Group Health Plans. In other words, MSP GHPs. Medicare Secondary Payers, MSP, and GHP is group health plans. This is a part 1 or 2, so we'll have a second part, and you might want to consider watching that. If you're watching in the on-demand, you will need to look for that video. So what are we doing today? Well, the first thing that we're going to try to do today is to look at the information that's available, and we're going to try to define what a group health plan is. Now, this definitely can affect claims processing, but if you don't understand the basics of what a group health plan is and what you have to know about it, you may not be able to get to that other information, or you may not be able to get to the necessary information to make your claims process correctly. I will provide you a bit of information on MSP basics. That basic information isn't really about employer group health plans or group health plans. The reason that I say that is because some of the questions I got in when I looked at them um, were really basic questions, so I don't want to leave anybody behind. Also, we will address any of those questions that were not answered in today's presentation or in Karen's summary tomorrow in her session. We'll then talk about Medicare eligibility, because Medicare eligibility affects certain things within an employer group health plan. And then we'll talk about some patient resources to help as well. So lots going on today. Please remember the acronyms are always going to be spelled out in the bottoms of the slides, or if you need me to spell them out or Karen to spell them out, please ask us. There is a lot of acronyms in the Medicare world. I'm going to give it a second. Karen, did my computer catch back up? In other words, can you hear me fluidly?
I can hear you, but right now we're on the agenda and objective slide.
Okay, hold on, y'all. Sorry, I'm waiting for my computer to switch. It's not doing it. Oh, there we go. Does it say just the basics now?
It does.
Okay, sorry everybody, having a little bit of technical difficulties. I'm not sure what's going on. So let's start off with some basic information. Now remember, the basic information is just reviewing general MSP information to help answer those questions and to get everyone onto the same page. So let's get started with that. One thing I want to remind you before I move on any further is just because an employer offers health insurance, Medicare does not require someone to take it. That's their option, right? So we'll talk more about who it's offered to, things like that. But I want you to always keep that in the back of your head. Just because it's offered doesn't mean it has to be taken. Once they take it, though, then we have to look further into whether they're primary. And that's what we're going to focus on today. Definition: healthcare coverage sponsored by an employer or employee organization. Someone asked me about that employee organization. What I'd like you to really think about with an employee organization is self-insured plans. How about a federal health government sponsored plan, a union plan, an employee health plan, or a welfare type funds plan? And then, there are the true employer organization plans, one that you get because someone is working. So that's what we're talking about there. Those are just the examples on the slides. So when we really look at it, it's very important to keep in mind that when we say employer group health plan, we're talking about an overall category. There are subcategories that go with that. So let me give you an example that might kind of tie that together. You'll hear the term disabled, age-related, or ESRD. I'm going to define those a bit more later, but those are the subcategories that are under the main category employee group health plan. One thing to keep in mind when we talk about an employee group health plan, does it have to be one employer? The answer is no. It's going to look at the total number of people on that plan. And I love to use my friend's company for this one because he actually has 7 employees. That's all he's got. But he joined what is called the collective insurance. It's just the name they have for it. Don't get hung up on that. It's not anything other than the name. But because he joined that to offer his employees insurance, he now is subject to 27 different small businesses who all came together to join this collective, and they have 231 covered employees. So they will consider the 231, if that makes sense, versus the 7, which is just his individual, because his plan is bigger. He didn't just individually sponsor it for his own business. So hopefully that kind of helps you understand when we talk about, hey, it's really a bigger plan. Same thing with a union plan. A small company can have a union. That's not a problem. If the union sponsors the health plan, which they used to do all of the time, then we look at the total number under that union plan. Those are kind of just some different scenarios that we're looking at. One thing to consider when we talk about employer group health plans, or EGHPs, is that it has to be an active employment plan. Well, that makes sense. Like, yeah, you have to actively be working, but who has to actively be working? Well, yeah, the beneficiary themselves, they can have their own plan. They can still be working even though they have Medicare eligibility. They do not have to be 65 or older. That is a common misconception. They can be disabled. Okay, that's a different situation, and we'll talk more about that in a little while. They could also have end-stage renal disease and be eligible underneath that, even though they're still working, but they are getting dialysis while they're working. Those are 2 different options. It could also be their spouse is the one actively working. They are legally married, not a partnership plan. Partner means you're not legally married, but recognized and they're paying additional premiums and things like that. But if you're legally married, then it's your spouse. I was asked really quickly about the child. And the child is if the child is the legal guardian of the parent. So think of it more encompassing of legal guardian. Same thing, if you have a disabled child who's eligible for Medicare and they have a foster parent, that's a legal guardian. That's what the other means, okay? Now, active employment can include retiree plans and other things like that. It's really not our job to determine that. That is determined by the Benefit Coordination and Recovery Center. So there's a bit of more information that goes with that. The reason that it can include certain types of retiree plans is how does that plan consider you? What is the employment given? It's less and less common that they're included. I will tell you that. It's becoming more and more infrequent because of how they classify. So just a bunch of different scenarios that go together with that one. Somebody did ask, is there an employment criteria that goes with this? And the answer is yes. Actively working as an employee means, yes, you are self-employed. That would be a situation like my friend. He owns the company. He employs himself. Yes, he is considered self-employed. His spouse or legal guardian is also employed. She, his spouse, does work there. He employs her, so the spouse is employed. Associated with an employer in a business relationship, sometimes board members or other types of people like that can get insurance based on that association. So while they may not be actively receiving a paycheck, they're doing something else important for the business, and that's where they're getting it from. So they're carried on an employer plan and they're meeting all of the following. One, they are not actively working. Well, why are they carried on an employer plan then? Great example. What if you're on PTO, right? You're still considered actively working, according to a lot of people, but are you going into your job every day? Are you logging into your computer? You're not doing that. So yes, you're actively employed, but you're not working. Okay. Short-term and long-term disability or sick leave from the employer, any of those. When you look at it, the truest way to look at it is that person active on the payroll for whatever reason? Again, PTO, great example. Short-term disability, they're taking that. Maybe they're just on their regular sick leave before any disability kicks in. So yes. So with that, again, it can go to a spouse or anyone else that's involved with that, just based on what's happening. This was a great question that I put, oops, sorry, self-employed. If you're talking about a person themselves, you don't include them in employees for determining the number of employees. The number of employees comes into account when we talk about the subcategories for employer group health plan. So it's how many do they employ, but not me. So my friend himself, though he is employed and has that insurance, he doesn't count because he's self-employed, working on his own. Okay. Covered services. One thing to keep in mind when you're talking about employer group health plans, EGHP, all of that, you're talking about all services that are covered by both Medicare and the plan. And the plan. No, Medicare does not tell a plan that they have to cover certain things. One of the examples that was given is the person gave us an example where the other insurance does not cover anything related to mental health. If it has a mental health diagnosis as defined by this other insurance, it's not covered. So it's automatically not covered. What you can do is bill to them, get a denial, and then Medicare will consider that because we do cover many mental health services. You would consider that as primary. We have to have the denial first because it's not all mental health, never covered. There's no way to do that with that type of services. So both plans have to cover it in order for Medicare secondary payer to come into effect. Medicare does have to consider our frequency, our medical necessity, and our exclusion list. If Medicare doesn't cover it and the other plan does, the patient may still be liable for whatever that other plan left them with as a liability, whether it's a deductible, whether it's a copay or a co-insurance, whatever that happens to be, because it's not covered by Medicare. So it has to be covered by both the other insurance or the other payer and Medicare. Does that make sense to everybody? And I hope it does. Um, oop, there we go. There's a couple of just quick reminders that I thought might be good things for you guys to have. Before we get too far into the different items that affect what subcategory the person falls into, we do want to remind you that group health plans are primary and they will assign patient liabilities. Medicare premiums and late penalties still apply along with all Medicare rules. All Medicare rules. So just because they have a primary insurance doesn't mean suddenly you don't have to follow the prior authorization for hospital outpatient department rules. No, you still do. It's still Medicare. So when you're really looking at that, yes, we had a interesting question or a scenario where the patient didn't pay their premiums and all of a sudden had late penalties. That is part of it. Medicare does apply a late penalty if you're not paying your premiums for the entire time. And in that case, you may only have Part A or Part B, depending on which premium you're not paying. So yeah, this might be covered if you were inpatient, but the rest of the Part B services aren't covered, or it could be the opposite. We could cover physician services and supplier services in Part B care, which would be outpatient hospital, things like that. But we may not cover any inpatient care because they didn't pay a Part A premium. So it's important to make sure everyone is aware of that. It's not like a credible coverage situation or anything like that. It just doesn't work that way. Some things group health plans can't consider that they cannot look at. One, they can't change deductibles, they can't change copays or premiums. They can't do any of that when someone has Medicare. Just because you have Medicare doesn't mean you get to do that. They offer it the same across the board. They also cannot terminate or not offer the employer group health plan. It's not possible. They cannot impose limits based on Medicare any differently than they would if the person did not have Medicare. So let's say they say, oh, Medicare only covers this many days in a hospital, 100. I'm sorry, skilled nursing facility is 100, hospital is 90. So we're going to impose that same limit once you hit Medicare. It really doesn't work that way. If they give you 300 or 365, there's no limit on it. They can't change it just because you became eligible for Medicare. They cannot charge a different premium for that. And they cannot force a person to take Medicare. They can't do it. If that person says, I don't want Medicare, it is what it is. Then they may have that employer group health plan, but they don't have to have Medicare. So this is where we get into defining the subcategories, because the Medicare eligibility is what affects the group health plans, and it affects the number of employees on that plan, and it affects what you get that for. Now, that means, would you have different types of items that are definitely affected, and how does that affect based on Medicare eligibility? The first thing I want to remind everybody is Medicare Part A and B is referred to as traditional fee-for-service Medicare. And why most people, about 99%, actually do get Part A for free, there is a percentile, one, that do have to pay for it. And that premium varies based on the number of quarters they have worked in their lifetime. So just use 2026 as an example. If they have worked one quarter to 29 quarters, they're going to pay $565 a month. If they've worked 30 to 39 quarters, they're going to pay $311 a month. And once they hit 40, it's free. That's why some people opt not to take it, which means that for an inpatient stay, such as a hospital or a skilled nursing facility, there is no coordination of benefits. There is no primary payer situation, and this doesn't apply because they don't have that type of coverage. There's also Part B. Now, Part B, which is again part of that traditional fee-for-service Medicare package, is always premium based. You got to pay some premium. Now, Medicare will sometimes rely on Medicaid to pay that in certain situations, but that's not what we look at, is do you have it? So it does require a monthly premium. It does vary by income. So it'll adjust up or down. What we do have is a base level premium of $202.90 this year. Now, along with both of those, Part A and Part B, each one has a deductible to pay. So it doesn't matter that you have an employer group health plan, Medicare still applies a deductible. In Part B, that is an annual deductible of $283. That's it. In Part A, it is a episode of care, benefit period, however you want to refer to that. And then it is 1,736, and it will restart if you have a 60-day lapse in inpatient care. So the deductibles, the premiums, if you're thinking about paying for Part A out of pocket, which can happen again, but only about 1% of the time, it does definitely affect that. So when you are trying to determine whether someone has an employer group health plan and it is subject to Medicare secondary payer, you must first go back and determine their Medicare eligibility. Do they have A? Do they have B? Do they have C? Do they have anything like that? Now, Part C is one that I haven't mentioned yet, and that is what is called Medicare Advantage. And what it is a replacement plan for traditional fee-for-service Medicare. If the patient elects this, then the Part C or the Medicare Advantage plan is their Medicare coverage. It is not a primary or a secondary or anything like that. It is their Medicare coverage. And the patient must then follow the Medicare Advantage plan rules, the MA rules. That does not mean that each MA gets to ignore primary payer situations or things like that. They do have to follow them. You know, they can have a little bit of a different situation because they can pay benefits a little differently and things like that. But what they're following and the basis for what they have to do is still established in the Social Security Act, just like it is for traditional fee-for-service Medicare. So it doesn't change that. Okay? So that brings us to the end of that for the different types. And again, we'll get more into it, but I wanted to make sure everyone was clear on that you don't have to have Part A. You don't have to have Part B. You may only have one. And in that situation, you will be primary for some services and secondary for some services, or Medicare will be primary for some and secondary for some. Can be a bit confusing, and so you really do need to check eligibility. Check Medicare eligibility, but then also check the Medicare Secondary Payer files. Again, it's all in the eligibility files, though. We'll talk more about that. I was asked about double coverage, and what that simply means is, can someone be eligible for Medicare for more than one reason? And the answer is yes. You can be eligible for Medicare because your age and end-stage renal disease, or your disability and end-stage renal disease, either one. And it's really dependent on how you are listed in the Medicare eligibility system. It isn't really something that we have any control over. And the reason that I say it that way is the Social Security Administration controls that. Then once they update that, the Benefit Coordination and Recovery Center actually has to go in and update their records based on what's in the Social Security record. So it doesn't automatically transfer to them. It doesn't have anything to do with us as a payer. We don't even see that. So we just follow whatever the BCRC has in the COB system, or Coordination of Benefits System. So great. One thing that cannot happen is someone cannot be simultaneously age and disability at the same time for Medicare. That can't happen. So if you're disability, you will stay disability until the system gets updated to show that you're aged. Sometimes that actually means the patient has to contact the BCRC to say, hey, why aren't you checking this? Or hey, why can't you update this? But that's on the patient to do that. Now, why is all of that important? Because it affects the coverage. It affects when an insurance is primary and secondary for certain levels and certain employment criteria. So that's key. Okay, that's why it's important. Which brings us to something called working aged. This is an employer group health plan. Okay, just the basics. And this is when someone is eligible for Medicare and is 65 or older. So that means that they are at the age of eligibility due to working. Now, again, they can work either premium or non-premium. They can have worked all of those quarters. It just depends. But I want you to move to the second box on the slide, because this answers some of the questions that were submitted. Medicare eligibility does not begin on someone's 65th birthday. It does not do that. Medicare eligibility begins on the first of the month in which that person turns 65. So if you have a birthday and your birthday is August 26th, you become Medicare eligible on August 1. Okay. But taking that a step further, you become Medicare eligible on the month prior if your birthday is the first of the month. So if you have an August 1st birthday, what day do you become eligible? July 1. It's a little bit different there, but it's still defined by 65. That's what we call 65. Okay. One thing to keep in mind when you're looking at working aged eligibility. So you're looking at 65 and older, and that's where they're eligible for Medicare. It does not have a coverage designation for services. It's not like it's related to kidney failure. It's not like it's related to a broken arm that happened at work. Nothing like that. That's a different type of coverage, and we'll talk more about that. Okay. So it's all services regardless. What's the caveat? If the other insurance doesn't cover it or Medicare doesn't cover it, then that is the caveat. Then it's not for those services. Also, when we look at this working age and we look at they're eligible because they're 65 and older, we have to look at the number of employees on the employer group health plan. And this is where it gets a little confusing for some people. It's 20 or more full-time employees or the equivalents. We use equivalents because of the example that I gave you with my friend. He does not employ 20 people, but he is on a collective plan, which does have 20 people. Again, that's just the name of the plan he's on. It's over 20. So 20 or more full-time employees in total. That is when Medicare is primary. if it is a small group health plan, some people call it an SGHP, whatever you want to do, that means it's under the 20 limit. That one will never be primary for Medicare, always be secondary. Now we see less and less of those, but we at the MAC, the Medicare Administrative Contractor or the claims processors, we do not determine primary and secondary coverage. Again, that is done by the Benefit Coordination and Recovery Center. Okay. The next type is what is commonly referred to as disability. Okay, disability. Here's the thing with disability. They have to be deemed Social Security disability. So they're receiving Social Security disability income. Normally it is for 24 months and they are under the age of 65 because remember we said disability and working cannot go together. Disability and age related as subcategories can't happen together. Okay. Someone asked about an exception. One of them that they asked about in particular, ALS, Lou Gehrig's disease, that is an exception, and that is not something we will determine. Again, this is something that is determined by the Social Security Administration or Railroad Retirement Board. Now, for us at WPS, it has to be the Social Security Administration. We don't work with Railroad Retirement Board claims at all. Okay. How long do they have to be typically receiving this? 24 months. Why is the bottom item in the middle where it says backdated important? Do you know that if someone says, no, I really am disabled and they fight with Social Security to get those benefits, however you want to say that, they appeal, they do whatever, Social Security can actually backdate their benefits more than 24 months. And then you have to use another type of letter and you have to let us know and do a bunch of other steps, but we're not going to get into that today. I just want you to know that the 24 months can actually pass without having any of those claims being submitted to Medicare because at that point they did not show as Medicare eligible. So there's some time frames that go with that. Again, with disability, it is for all services. But if you notice on the third item and you look down, it says 100 or more. Same employment criteria, same everything like that. It's just the number. So in a group health plan, it was 20. In a disability, which can be called a large group health plan, it's 100. Okay. So even if someone had Medicare eligibility, they were under 65 and they had 80 employees, Medicare is still primary because they haven't reached the 100. That same exact person continues on that group health plan with their spouse, but turns 65. Now they contact the BCRC, Benefit Coordination Recovery Center, to update that, and the criteria changes to 20. So that means now which one would be primary? The other insurance. Does that make sense to everyone? Hopefully it does, and I didn't miss anybody there. If you did or you need more information, please feel free to throw that down into the chat. Next type is completely different, and that one is end-stage renal disease. This is a form of Medicare eligibility for those that have kidney failure. Okay. Now, Medicare does usually start in the 4th month of dialysis when the beneficiary when the beneficiary participates in dialysis at a facility. Admit to a Medicare approved hospital for a kidney transplant, which could occur before that, depending on the situation, would begin their coverage. Also, if there are treatments that are needed before the transplant, those would also be covered. Typically in the same month or, a few following 2 months, something like that, or following a few months after the transplant, the coverage can continue. I want you to remember that with end-stage renal disease, it is a little bit different than the other types for an employer group health plan because it was written in a different section of the law. So it has some different items that go with it. First, it's not about the number of employees at all. What it is about is the coordination period. And you can see in the last one, it says covered for all services, not just about the end-stage renal disease stuff, but all services, and that it has a 30-month coordination period. What that means is during the first 30 months of eligibility, Medicare is secondary and the employer group health plan is primary. Once that 30-month passes, then it switches and Medicare becomes primary and the employer group health plan becomes secondary. So it's 30 months. It has to be 30 months. Okay. But again, no like number of employees. In this section of the Social Security Act, which incorporates the end stage renal disease employment rules and things like that with the employer group health plans, it also adds an additional caveat that is not in the other two types. The coordination of benefits period, which we talked about being 30 months, applies if they start COBRA before they become eligible for Medicare. So they do have a COBRA plan, they're taking that, and then all of a sudden they're eligible for Medicare. We still use the same 30-month coordination period for Medicare eligibility. Can 30 months have passed with someone not being eligible and then they have a backdated eligibility? Absolutely, it happens a lot. Why does it happen? The doctor must report it. So that's part of our coverage criteria here. Medicare eligibility is due to kidney failure. And again, we did say it does start the 4th month of dialysis or when treated in a dialysis facility. That's not an or, that's an and. For home dialysis, it is a bit different. It does start much sooner. But again, that's up to the Social Security Department to decide. Admit to Medicare approved hospital for kidney transplant and for healthcare services needed before a transplant. Okay. So we're looking at a bunch of different pieces of information when we talk about this. But I want to remind you that one of the things that starts the end-stage renal disease coverage is a medical professional needing to do a report to the Social Security Administration to tell them, hey, by the way, this person has end-stage renal disease, and here's the diagnosis that goes with that. It doesn't have anything to do with us at the payer. We can't do anything with it. I was asked a question by a confusion or a provider that had some confusion. What happened is they had an end-stage renal disease patient that did have a successful kidney transplant, and all of a sudden their Medicare coverage terminated. Now, in this case, the person was in their 30s in this situation given to me. So what happened is 3 years, 36 months after the kidney transplant was successful, their coverage did terminate. The one part that does not is the anti-rejection drugs, but that's not paid through us. That's paid through a prescription drug plan. If for whatever reason the patient chooses to stop dialysis, they are given 12 months more of Medicare eligibility, but then that will also terminate the coverage. So when you look at Medicare eligibility and you're like, they did have coverage, but they don't right now, one of these situations did apply. I'd really like to move into the next section, and this is where we're going to get into some of the questions you guys had quite a few of. And again, Karen's going to summarize this tomorrow and then answer all those questions. But I want to remind you that checking eligibility for group health plans is more than a one-stop thing. You may do it a couple of different ways, and so that's where you might have to check a couple of different items. So, all right, first, you do have to ask the patient. And there are questions that you have to ask the patient. There are a logical flow in the CMS Medicare Secondary Payer Manual in Chapter 3, and it's Section 20.1 or 20.2.1. We'll go to that in just a moment. The logical flow says, hey, do you have eligibility for Medicare? Yes. Do you have an employer group health plan? Yes. How many employees? Hopefully the patient knows that, but not always. Sometimes that's what they don't know, which is why you're going to rely on a system. And then get whatever information you need to submit the claim, right? What's the name of the plan, things like that. So there is a little bit of a discrepancy between a facility who bills on a UB04 and 837I and a professional or supplier or other who bills on a CMS 1500 or 837P. Someone asked, what is that discrepancy? Facilities, again, the UB04 837Is, you guys have much stricter guidelines as to when you must ask. So first, you have to ask on every inpatient admission. Even if they're only gone for 2 days, it's a brand new inpatient admission, you're asking again. You do have to ask at every start of care. That's your outpatient criteria. And then if that care happens to be something that is a reoccurring service, dialysis, maybe rehab therapies like outpatient rehab, like PT, OT, and SLP, right? Those types of things. We know they're going to come back. Then you have to ask every 90 days. This is different than people that bill in a 1500 claim form or an 837P. How it's worded is you have to ask as often as possible to determine who is primary. What does that really mean? There is no set limit. Like you may see a patient every week and you don't need to ask every week, but you may see a patient every 3 years. So you need to set up a time frame that works for you to make sure that the information is staying the same. Here's what we, WPS, recommend. Fall back to the 90-day rule. Ask every 90 days. It is a recommendation. It is not a requirement for those that bill in a 1500 claim form or an 837P. Not a requirement, just a recommendation. Okay. Now, Medicare does say you can ask the questions in a paper format or electronically, but you got to keep whatever you ask for 10 years. On the bottom, you'll see that reference that I gave you. So let's just go there for a second. I'm not going to go ahead and jump through it, the channels to get there. I'm just going to go ahead and use the link on the slides, which again, you'll have access to in a little while. Or, okay, I'm like, or not. And so what it's going to do is it's going to open up the power, it's going to open up the website and it's going to go into the Medicare Secondary Payer Manual. And I said it was 20.2.1. So here's where we have the verification. You can see it's 20.2.2. And here's where we have the model questionnaire. So each one says yes or no, and then there are questions dependent on that. That's why you have part 1, part 2, part 3. So these are yes or no questions to try to get all of the information you need. Okay. Do you have to ask these exact questions in this way? No, but you do have to gather the information to bill correctly. So that's the MSP questions. I thought it was important to show that to you what CMS has written out and then to remind you that yes, you do have to keep them for 10 years. Now, it doesn't, again, you don't have to ask these questions. If you do this electronically, great. Another thing that CMS does allow, and this will be on your next slide. So this we're going to move on to slide 20, and it says eligibility resources, is to look at an electronic tool and see what that electronic tool has for primary payers. And then simply ask the patient, is this still relevant? If you do that, you're doing this questions right here without having to go through all the questions. It's fine. Could you do that as part of their admission or part of their paperwork to come to you? Absolutely. You can do it electronically without ever verbally asking the patient. No one said it has to be verbal, but you do have to get the information. So hopefully all of that does kind of make a lot of sessions and a lot of answers there. What I'd like to do is just show you one tool that is free as long as you are a WPS jurisdictional provider. What that means is you are either in J5 or J8. J5 is Iowa, Kansas, Missouri, Nebraska, and some UB04 and 837I billers across the nation. J8 is Indiana and Michigan providers, both Part A and Part B. Okay. Now, I will tell you, yes, if you're looking up general information, you do have to go to Part A and Part B, which is CMS line of business. But for this purpose, we're going to go to the portal right here. Here's the portal. Inside the portal, you have the portal user manual. What is great about the portal user manual is you can download the entire thing in a PDF version, or you can simply scroll down and see the different functions. I'm going to scroll down, and what I'm looking for is the header. And the header is called patient because I'm looking at patient information with the subheader of eligibility. If I open this page up, it'll walk you through what you can find, different things you do have to know, all those types of things, right? But what it also does is gives you screen by screen look at what you're going to need. Okay. You're going to do an eligibility search. It's going to supply supplemental information and eligibility. You want to use eligibility. Supplemental information is for insurances that follow Medicare, not what we're looking at. Remember, it has to be primary. So eligibility. It's going to give you a summary of the information that you entered, and then it's going to allow you some options. It will automatically default to summary, and you can see that here. But what it does is just gives you the basic benefits. This is not where you're going to go to be like, oh yeah, I have all the MSP information I ever needed. No, this is just your basic benefits. So as we scroll down, you'll see it coming up with these different boxes. Okay. And you'll see the one we're looking for is MSP or Medicare Secondary Payer. In this example, it is grayed out, which means there is no information, but we can go there and find out anyway what is there. So I'm just going to scroll down. Look away, please, if you don't like a fast scroller, it causes you a headache or something. I want to do that, but I do need to get down to that information. So we're scrolling, we're scrolling, we're scrolling, we're scrolling. And what we're looking for again is that Medicare secondary payer information. And so you can see, okay, here's our tab. It's labeled Medicare Secondary Payer MSP. So again, you'll notice it as an MSP. What this will do is gives you a little brief explanation of it. And then it actually explains what you'll find here. One of the questions that was really good that I got in is, why doesn't it always have every field completed? We don't know that. What we can tell you is this comes from the HIPAA 270, 271 standard transaction. So if that standard transaction or that response doesn't contain something, it is left off. It's just not there. But it's also not something we can give you. Okay? So when we talk about employer group health plan, please check your source codes. This will tell you what type or what subtype it is. We know it's an employer group health plan, but the source code actually defines for us what else there is within it. I'm going to stop for a second. I'm actually going to ask Karen because she does a lot more education on this than I do. Does she have any other tips or advice for you on looking at our portal and regarding MSP? So Karen, do you have anything you'd like to offer to help them?
I will say that I did do a webinar on eligibility that's out on our um, YouTube channel for the encores. So if that is something that you're really interested in, I do show actual examples of the information that you can find on that MSP screen. But that is a good place to start. Thank you for bringing that up, Tom.
All right, thanks, Karen. Like I said, Karen is the one that actually does the portal education. So sometimes I have her throw in. Somebody did ask me about HETS. And let me just go to the cms.gov website. And I'm going to search the word HETS because we use HETS to give you the information in the portal. So what you'll find out is it's the HIPAA Eligibility Transaction System, or HETS, which uses the 271 eligibility request and the response of the 271. Exactly what I just said, 270, 271. You can access